from Dr. Asif Imam, and he will be talking on quality assurance in primary healthcare. Dr. Asif Imam.
Thank you, Dr. Zaki. Bismillah ar-Rahman ar-Rahim. I'm going to change gears because we've been hearing basically guidelines and concepts, but what I'm going to do today is just kind of tell you about a practical solution of quality assurance, especially primary healthcare. And hopefully you can get some tips so you can implement it in your organization. Just a little brief background on the origins of this quality assurance. This is basically developed by Sina Healthcare Systems. It was started as a prototype primary health facility in Baldia town in 1998. And there were two objectives when we started this prototype clinic. One was to evaluate these existing primary healthcare systems in Pakistan. And the second object was learning from that experience to develop an indigenous, practical, evidence-based, quality-managed, auditable primary healthcare system for developing countries. I know there's a lot of words in there, but I think each word has its weight. Indigenous, we cannot take foreign solutions and put it in. We have to develop our own systems. Practical, it shouldn't be that cumbersome. It should be easy, simple to implement. Evidence-based, we all talk about evidence-based medicine now. So, for example, giving an antibiotic has to be evidence-based. So all these things were taken in account, and we tried to develop a comprehensive system. And the important thing was that we develop a model which is replicable, and replicable in the developing countries where resources are very limited. So this was the basic objective. The vision of Sina Healthcare is to provide quality primary healthcare which should be accessible to everyone in our society. And I think the theme today is that quality, quality, and actually even before quality, like Dr. Murad Musa said, ethics has to drive everything. But ethics, if you have the ethics, then you have quality, and you cannot have it the other way around. So our quality mission was to develop a standardized, quality-managed, indigenously compatible primary healthcare system for widespread application in Pakistan. So this is the system that we have developed over the last almost 12 years. Now, when we started developing this, there were certain components that we had to develop from scratch. The first thing was there was no standard operating procedures in primary healthcare, so we had to develop that. Then we had to develop the quality management documents and procedures. You cannot have quality assurance without documentation. So those were the tools that we developed. Then you have the system and the documents, then you cannot just implement it without training. So we had to develop training of the staff in a standardized system. And then after training, you want to make sure it's implemented. So we had to develop the quality auditing procedures and tools. Once we have the results of the audit, what do you do with it? So we come up with remedial and reprimanding policies depending on the audit results. So there are 7 components which are very important, and I think as we have seen in this conference that everything has to be patient-centered, and this is what we are doing. The first and the critical, or what we can say the tipping point in any quality environment is the doctor, the leader who is giving the care to the patient. So we have to develop a system in which the doctor to patient healthcare delivery quality is monitored. Then when the doctor gives a treatment and then the patient goes to the paramedic or the chemist, then you have to have a quality control system in which you're monitoring what the paramedic is doing to the patient, and then what the pharmacy is doing to the patient, what kind of medicines he is giving to them. We also have a small lab, and then we also try to develop a laboratory service quality parameters. And then we have already heard about infectious disease control and facility hygiene quality. So we have developed, all these systems as we have come along the last few years. We also have what we call a medical instruments calibration and maintenance program, and then facility administration. How do the management, manage the facility? What kind of, flows that are to put in place to get this patient satisfaction quality. Now, as I said earlier, that unless you document the care, you cannot monitor the quality. So we developed a record keeping system in which each patient had a medical record, and a lot of us think that it's very expensive to do that, but I think we have proven that it can be done in a very modest cost. And then obviously the patient identification card is very important. So this was the first step. Now, when you have the doctor as a central criteria for quality of care, then we have a very robust system in which when we recruit the doctors and how they go through the quality loop. So there are 6 things that we do. First is that we have criteria when we employ the doctor, and I'll show you the forms that we use. Then we just don't get the doctor and have him say, okay, you go and start your seeing patients. We have a pre-employment or induction system training. Because we have developed a system, it's our duty to let him learn what the system is so he can implement it properly. And then once the delivery has started, then it has to be documented. And this is one thing which is not in our culture. We don't like to document anything. But I think if we have a very robust system, we can make sure that they do it by monitoring. And then once the care is documented, then we audit for the quality of the health care. And then if there's a problem, then we actually retrain the doctor on the job, and with a program that I'm going to present in a minute. And then, as we said earlier, that remedial measures or reprimand. Actually, we have fired doctors who do not perform to the standards that we expect from them. The employment criteria that we use is basically, since we have primary health care, we have family medicine, we need a family medicine experience, and we do prefer FCPS or MRCGP because obviously they understand the concept, the quality concepts, better than the untrained physician. And then we actually have an entrance test to see their, the various aspects which will impact the quality of the patient care. And I've already mentioned the pre-employment induction training, which is a must before we can implement a system. This is a candidate evaluation form that we use. It's quite elaborate, and just to show you an example that everything has to be documented and systemized. This is the core of our quality. If you don't train the staff, there's no way you can get quality. So this is what we call a Sina CME system, and it's a very elaborate ongoing system, as you can see, that it actually starts with if you look at the bottom, we have a half-day group teaching session every month for all our doctors. And then we have other components to it. We have pre-reading materials, and then pre and post session MCQs. And then we're using the mobile technology to educate our doctors. We have monthly audit of the doctors and the paramedics, and then we also have one-to-one teaching, if there is a problem with their performance. And then you can see that we just hold the hands of the doctor and the paramedics and take them along with us. We also have a half-yearly one-to-one review and professional development, personal development of professional, and that is important because we want our doctors to set goals. We don't want them to be stagnant. they need to be moving up in their education, and their so you can have the quality that we require of them. I'm going to just rush through the next few slides, and a lot of it is a kind of repetition. Basically, we have patient files, registration cards, and we have algorithms, protocol algorithms, which we teach our patients, and we teach our doctors, and we have them fill that out. This is an example of a fever protocol, and as you can see, this is a very comprehensive protocol in which we make sure that the doctor is taking a proper history, he's doing a minimum physical exam, he's making a diagnosis, and then he's treating the diagnosis according to evidence-based guidelines. And just a little bit on the Sina audit system. Basically, we have protocol-based audits, clinic-based audits, and one-to-one feedback to every doctor. And this is the form that we use for the audits of the doctors. And this is the clinic-based. That's a protocol-based audit you saw previously, and this is a clinic-based audit. And then we have half-yearly evaluations of doctors, which is every 6 months. And then we help them improve and set goals for their personal development. This is the form for half-yearly evaluation. This is the personal development of professional of the doctors. Then we have evaluation, criteria for the paramedics. We can just go. We actually have training of the paramedics, so they can. We make sure that whenever they're taking the blood pressure of the patient, they're doing the right way. This is a TPR station in which we teach our paramedics regarding proper taking of the vital signs. This is a dressing station, dispensing station, and then we also have a pharmacy system which is quality controlled. We have a standard formulary. We only have GMP certified medicines, and then we have the inventory control and hygienic practices. Sina laboratory services, we have internal assessments and external assessments, and then we have the Sina infrastructure maintenance, in which we audit the whole facility and then do corrective measures. This is a form for the center audit, and we have already heard about the infectious disease control system. We have a standard operating procedures for instrument sterilization, and then we have a waste management system in which we have the general waste, the shops, and the other infectious material. And this is the loop that we have. All the waste material in our clinics have to go through a process, and they end up at the CDGK incinerator at the proper place. And this is basically the management system of the administration. So, thank you.